Welcome to episode 2 of the MRCS, part A revision series. In today's episode, we will be covering open fractures. This will include the classification, management, and on-call essentials. Let's start with the definition. A fracture with overlying soft tissue injury that is allowing for communication between the bone and the outside world. Why is it important? Exposure to the outside environment introduces significant infection risk. Infection impairs wound and bone healing. It can also develop into systemic illness, shock, and threaten loss of limb and life. An open fracture also indicates the amount of force or trauma suffered by the soft tissues. The classification method. The system used is Castillo-Anderson. This classification is only applied after surgical exploration and assessment. Type 1 skin opening less than 1 cm, quite clean, likely from an inside to outside injury, minimum muscle contusion. The underlying fracture is simple transverse or simple oblique. Type 2 laceration between 1 cm and 10 cm, extensive soft tissue damage such as flaps, avulsion, or moderate crush injuries. The underlying fracture will be transverse or oblique with minimal comminution. Type 3 a laceration 10 cm, adequate bone coverage. Underlying fracture is segmental. Gunshots are also classified in Type 3A. Type 3B laceration greater than 10 cm, periosteal stripping, bone exposed, massive contamination, will recover soft tissue coverage. Type 3C is a vascular injury requiring repair. So, how to manage? Non-major trauma or low energy. Take a history and examination. Investigations, FBC, renal profile, bone profile, clotting, group and screen, CK. X-rays. Treatment, analgesia, antibiotics as per local guidance, tetanus booster if needed. Remove any gross contaminant, but do not do a washout in ED. Photograph the wound, dress with a non-adhesive dressing and splint the fracture. Check neurovascular status and get check X-ray films. Mark, consent and list for theater within 24 hours. For those who are major trauma or high energy. ATLS, history and examination. Investigations, as for low energy, but may also need CD for planning of comminuted bone with an angio if vascular injury suspected. Treatment, as with low energy, but will need primary washout within 6 hours. These patients often need multiple trips to theater. The bone should only be primarily fixed if relatively clean and definitive soft tissue coverage can be immediately achieved. In most cases, this is not the case, and external fixators are used to span the fracture whilst allowing time for the soft tissue injury to heal. On-call tips. The antibiotics are critical. Get them in early. And be wary of compartment syndrome in these patients. Thank you for studying open fractures, a common on-call case and also common on the MRCS, Part A with me. If you found this video useful, please like, and to ensure you don't miss any more study sessions, remember to subscribe and hit that alert bell.